Okay, hello. My name is Dr. Shiraz Halloush. I'll be talking briefly about the cost effectiveness analysis, and I will explain the cost effectiveness plane. Then my colleague, Dr. Anas Al-Muhtasib, will talk about threshold and budget impact analysis. So first, cost effectiveness analysis is a form of pharmacoeconomic evaluation that compares the incremental cost and outcomes of different courses of action. This analysis should be conducted with intervention of the same outcomes, where we always have at least one comparator. The summary of cost effectiveness analysis is a ratio between the net incremental treatment cost and the net incremental effect. This ratio is called the incremental cost effectiveness ratio, or the ICER. The ICER is actually a quantity rather than a quality. The value of ICER is not that important, but it could have like a negative or positive estimate. There's a great misconception between the ICER and the ICUR, the incremental cost utility ratio. The incremental cost utility ratio is the difference between the incremental cost to the incremental quality. Quality describes both quality and quantity. So for instance, in ICER, the effect, for example, we can take the number of patient cases, or the amount of blood pressure decrease, or even the life years gained. While quality has both, it consists of the length of year and the quality of life. But both of these are used interchangeably, actually, in the literature. The cost effectiveness plane can be helpful in interrupting the cost effectiveness analysis. And this plane, it consists of the incremental effect in the x-axis, that is a difference between the effect between two medications, and the incremental cost in the y-axis. So for instance, if we took a medications that increase the quality, or results in 5 life years gained, with an incremental increase in costs for $50,000, this medication will be located in the northeast quadrant. This quadrant is actually called the trade-off area, where the decision is related to how much you are willing to pay for this. So if you want to talk about is the drug is cost effective, then the decision should be related to the willingness to pay. The other scenario, that if we have an increase in effect but decrease in healthcare costs, in this area, the cost effectiveness question is really easy, that the drug is dominating the comparator. The worst scenario, that we have a decrease in healthcare outcomes and an increase in incremental cost. This question is also an easy question, and the answer will be a no. This drug is worse than the comparator and dominated by the comparator as well. The fourth scenario, that we will have a drug that has both decrease in cost and effectiveness. This drug will be located in the southwest quadrant, which is the reversible or the reverse of the northeast quadrant. It's also a trade-off area, where the decision is related to the willingness to pay, or how much you are willing to pay for the additional quality or additional effect. So willingness to pay, this line, the red line, represents the willingness to pay. It's related to the society on how much the patient, or how much people or society are willing to pay for the additional effect or the additional quality. It's a widely used term, and it's a term widely used in pharmacoeconomics, and it's the maximum price per additional benefit at which or below the consumer will buy the product. So if you look at the willingness to pay line, any value beneath or below the willingness to pay will be a cost-effective medications. In reality, this scenario is totally different because we are talking about deterministic values in case-based points. But in reality, we don't have like an exact cost for each medications. We have a range of costs and a range of effects. So each value will be used, will result in a different ICER values. And all of these ICER values will be conducted together 1,000 times and redone. You can redo it again 1,000 times in a different simulation models to get the probabilistic and sensitivity analysis. So for probabilistic sensitivity analysis, there should be a line between the 2 points, and any value beneath this line will be a cost-effective, and any value above this line will be not cost-effective. So the problem of ICER is that it's the comparison in ICER is a pairwise based. We cannot simultaneously evaluate more than 2 treatments. And it's difficult to make decisions when data lies in more than 1 quadrant, like we said in the probabilistic sensitivity analysis. Thank you.
Okay, thank you, Dr. Shiraz.